friends. I am so excited to talk to you about the role of refractive surgery in low-income countries. And Dr. Katz, right before I started, he said, I didn't know that those two things go together. So I've got just 10 minutes to convince you otherwise. Now, when we talk about refractive surgery, be it corneal or lenticular, and we're talking about, is this really for low-income countries? Some of you may walk out the door saying, well, she's talking about giving Gucci handbags, those who are in hunger. And that's not the case. We have to learn to break down social construct, and we have to learn to understand historical perspectives in order to move forward. So in refractive surgery, some of us may think that it's the luxury sector of ophthalmology. Let's break down that equation into 4 foods of thought. The first one came up from yesterday's talk by Tulsi from Arvind. And I bring his words when he talked about the IOL revolution in developing countries. What did he say just yesterday? In quote, because I loved it so much, I recorded it. Probably the most important one, as far as the impacts in the Arvind eye care system, was the IOL revolution. This happened in '82, when the entire world literally formally took a stand that IOLs are not meant for developing countries because they're expensive, the microscope, the learning curve. That is when Dick Littman,
Dick Littman.
I'm so sorry. Thank you.
Richard Littman, amazing, amazing man. He's 88 and still doing great.
Thank you for that. And then later, Mark Spencer. Did I get that correct? Martin Spencer. This was my recording transcription abilities. From Canada came and demonstrated the surgery. And that goes to show that 2 people, he then went on to talk about how those 2 folks revolutionized IOL care and delivery, not only in India, not only in Arvind, but in the entire world, and changed the face of what it meant. So 2 people can make a difference, 1 person can make a difference. The second food for thought is when I talked to a friend of mine, a mentor of mine, Nariani, who was in residency as my mentor at University of Chicago, I said, well, why is it that refractive surgery is not thought of as a curable source of blindness or refractive error? And she said, well, it could be that there's a click fee for every time you use the machine. And that was instigated by industry, okay? So if we talk about laser click fee, every time, for those who are medical students and residents, every time you use the machine, you have a card. And that card, there's a click fee for every time you use a laser vision correction for a procedure. So let's talk about it from homes. Now I buy a $200,000 home, but every time I have to enter, I'm gonna ask you to pay an entry fee. How are you gonna feel about that? It's the same thing, right? So we don't accept something as silly as this, but we allow industry to come forward and give us a click fee for every time we use a machine that we have bought. And so how do we speak and start the discussions with industry? Number 3 is that refractive error, and this was a concept, again, I finished at Duke in my cornea and refractive surgery fellowship. None of these points were brought to me during the wonderful fellowship training that I had. It's only afterwards that these points started to hit me one by one. When Guy Kazarian, the founder of the Refractive Surgery Alliance, told me, well, Ashiyana, myopia is a congenital defect, and did you know that it's the only curable defect? Refractive error is the only, or I should say amongst the very few, if not the only, congenital defect that can be cured. And when it comes to the current state of refractive error management with glasses alone, I appreciated and loved Kanwal's talk in the midst of the turmoil, but it's not one or the other. We have to do everything we can. And unfortunately, the studies have shown that glasses alone is not doing enough. This is statistics as of 2015. I'm sure it's worse now, but in 2015, only $37 million was spent on delivering eyeglasses to people in the developing world. As much as we say it's a low-hanging fruit, what are we doing about it? That is, to give you an idea on the global scale, less than 1% of resources devoted to global health issues. So if we talk about it as a low-hanging fruit, let's do something about it. But if we can't use that alone, we need to look at other options. So this is, I would say in 2010, when I was at the WHO in Geneva, I was working on the global burden of disease study and identifying the prevalence of blindness and visual impairment in every part of the world. That was the global burden of disease study. And one of the things that we identified very early on in that time that I had there was this bottom line aspect that refractive error is the third leading cause of blindness and visual impairment. Okay, and we're talking about those that are over the age of 50, but that does not, and Conwell did a really great job about talking about children and those that are over the age of 50, but it does not stop there. It does not stop in children. That same problem translates into our teens, into our 40s, and into elderly age. And so how do we go about handling this? It did not change between 2010 to 2019. We did not affect change. So when we talk about the three leading causes of blindness, cataract, glaucoma, and uncorrected refractive error, it's uncorrected refractive error and cataracts that are the two curable causes of blindness. We know that its impact is drastic in terms of equality, inequality, in terms of economic burdens, in terms of productivity. We know that. And this goes without saying, 90% of blindness is preventable or treatable, and 90% of it lies in developing countries. And so when I finished up my fellowship, the decision was made, well, if the need is there, I have to be there. And that's the reason for my move to India to begin with. Now, when we talk about uncorrected refractive error, I brought this up and I'm going to emphasize this again. Glasses and contact lenses, yes, but we're just not doing enough. So in the realm of refractive surgery, what has been done thus far? We have sites through HCP Cure Blindness. The first one ever historically was started in Tilganga, Institute of Ophthalmology in Nepal. Dr. Kishore Pradhan was a big pioneer in this realm to be able to use refractive surgery lasers, and the income that goes from that, the profits that go from refractive surgery laser correction, was used in order to provide for other cataract surgery and other procedures throughout Tilganga. But we are now moving into Ethiopia. Later this month, I'm visiting Cusco to see what else we can do. How can we provide the opportunity not only to more places in the world, but also to be able to use it in community refractive surgery. Because I know there are some out there that say, wow, if we can hold community refractive surgery camps, well, why not? You know, why can't we move in that direction? This is an article that is from J.J. Hospital in Mumbai, and it was a site that is also doing refractive surgery. It has its own LASIK platform, and the idea that 25 fishermen got full vision because of refractive surgery. These are the stories. I'm in Mumbai, just imagine, but I didn't even know this story because we just don't talk about it. So there are pockets in this world that are doing it. We just don't necessarily know about it, and for sure, it's on such a low scale compared to what we need to do. So what is the role of refractive surgery in low-income countries? Well, talk about cost effectiveness. Studies have shown, I didn't have time to include that here, but that it is indeed a cost-effective measure rather than having broken glasses or all of that contact lenses. If you look at the financial models, you look at the financial trajectories, that it is indeed a potential cost-effective measure for refractive error correction globally. we need to use it also in the realm of breaking down cultural norms. It's the psychological and cultural norms that are affected when we talk about the classic example of the young females in India who cannot get married, believe it or not, because they either have glasses or contact lenses. Just 2 months ago, I was dealing with a lady from Pakistan who I was taking care of in Mumbai, and she needed scleral contact lenses for keratoconus, separate from refractive surgery. But she, even though we were going to provide the funding for her scleral lenses, said, my husband-to-be will not marry me because of this. And so I could not even convince her to accept the contact lenses. That's what we're dealing with. And so refractive surgery for normal corneas is definitely a way to push these barriers. How do we address profession-based obstacles like farmers who can't keep their glasses on, villagers, manual laborers, military? Just like, and Jeff Petty's in the room, thank you Jeff for putting this on, the AAO Global Ophthalmology Summit. It's a historic moment in our lifetime to have this in 2022. So too was Global Refractive Surgery Summit put together in March of this year. And it was the first of its kind in conjunction with the ASCRS, HCP Cure Blindness, and the Refractive Surgery Alliance, where we brought together all these folks who stand strong in this idea that we should be able to utilize refractive surgery for all. And let us move forward as the years go on to create history, to make a difference, to not think of everything in the same way that we used to. Let's try and break down the mindset of our young ophthalmologists. How can you get involved? Solutions to increase refractive surgery access is to get involved in the Global Refractive Surgery Initiative. This is our website, globalrefractive.org. Get involved with our working group. Work with industry to remove that quick fee. Get involved in political discussions, financial business modeling. Adopt an already existing refractive surgery unit. Education, education, education. Change the mindset of our young ophthalmologists. And finally, each and every individual refractive surgeon, wherever you are in the world, must resolve to increase access in their own practice and in their own backyard. Thank you.